Good afternoon, ladies and gentlemen. It's always a pleasure to come to Advances. This energetic young man does it. He's been doing it for 14 years, and I'm always impressed at the crowds he gets. And I guess it's because everything that we listen to here is all practical stuff, and that's something that we have to know about. And today I'm going to talk about postpartum hemorrhage, and I'm going to stick only to the management strategies because I think all of us know that PPH is probably one of the worst things that an obstetrician can face as part of our practice. If we look at a very simple definition of postpartum hemorrhage, it's best defined as blood loss that results in hemodynamic instability and necessitates transfusion. Very few of us, and I've practiced for 32 years, very few of us can actually say, she's a vaginal delivery, she's lost 500 ml. She's a cesarean, she's lost more than 1,000. It's very difficult to quantify. But you know you're having a PPH when the patient is starting to get hypotensive, and we end up having to give transfusion to help this woman. Now, when we're talking about PPH, it's completely two different stories if you're having a PPH after a vaginal delivery or a PPH after a cesarean, because in a vaginal delivery, your aim is to avoid a laparotomy. And that's why what happens is quite often in a PPH, in a vaginal delivery, there is a delay. We end up having, where is the timer? Oh, right there, okay. So we end up having a delay because we keep saying we don't want a laparotomy, we don't want a laparotomy, let's somehow avoid a laparotomy, and we start delaying, and that's where we get into more trouble. In a cesarean, it's easy. Everything is open. If whatever we need to do, whatever suturing we need to do, we can do right there. Now, there are certain prerequisites for you to have the ability to handle a postpartum hemorrhage, and one is you must have 24-hour coverage by obstetricians and trained personnel. The hospital, however small it is, must have access. You should be able to get an obstetrician in, and you must be able to get trained personnel, because it's a question of having protocols in place. You cannot have the proper management of PPH if you are on the spot trying to tell a nurse or a registrar or your junior consultant on what to do. You already have to have the protocols in place. I mean, when we start having a bleeding and it's excessive, I just have to say, this is more bleeding, and I start talking to the patient. And as I'm telling the patient that she's bleeding more, I can see my nurses getting ready to start another IV line on the other side. So everybody has to be trained. Everybody has to know that this is what we do. The second thing is you should have some basic lab facilities, and people like us who practice in small hospitals and who do not have 24-hour labs, you have to have some sort of connection with some lab who will be able to give you lab reports immediately. And also you have to have a very good rapport with your blood bank, because you know that all of us have struggled with it when you have to send somebody out to get the blood, or you have to have them come in with the blood, with the traffic, and Chennai traffic right now is atrocious. So you have to have very, very clear understanding about when you order blood, how long is it going to how long is it going to take to get to you. You also need to have theater facilities and personnel who are available 24 hours a day. You can't have, after 9 o'clock, if you don't have anybody who can come and help in the theater, you're going to be caught. So I'm talking about small hospitals like ours, because it's okay to have a multi-speciality hospital where everybody is running in, but small hospitals is where we need to be very, very careful, because we all have to deal with PPH, and you also have to have an anesthetist on call 24 hours. So what actually happens is that we need to be able to contact all of these people immediately. So let's just go through a particular case. Mrs. RH, 24 years old, gravida 4, para 1, has had 2 miscarriages with no live child, was admitted in active labor at 6 a.m. She progressed slowly. an oxytocin infusion was started. At 2 p.m., she was 8 centimeters dilated, and she was fully dilated at 3 p.m. The head was at +1 station. She had a delivery by vacuum at 3:30 p.m. The baby weighed 3.8 kilos. Classic case, large baby, slow progress of labor. So she's just sitting, a sitting duck for postpartum hemorrhage. We routinely give 10 units of oxytocin intramuscularly as part of the delivery protocol. And she received that. As the episiotomy was being sutured, she had a gush of heavy bleeding, and the uterus felt boggy. Now, when you have a situation like this, the first thing you start to do is start massaging the uterus. And with the massage of the uterus, she continued to bleed profusely, and she started to complain of feeling thirsty and started thrashing around, started getting very restless. You must remember that in young, healthy people, the first signs of shock may actually be changes in their mental status. When they start getting, start struggling, and at that point you start shouting and say, you have to be cooperative. I'm trying to see where you're bleeding from. Stop struggling, stop doing this. She's not really listening because there's less oxygenation to her brain, and that's how she's responding. So you have to get extraordinarily alert at that point. So the cardinal signs of shock are, of course, somebody is checking the blood pressure. When you are having this heavy bleeding, immediately your nurse starts checking the blood pressure every 5 minutes. There is change in mental status, as I mentioned. Cold, clammy skin, very classic sign of shock. And oliguria, so we also need to know, is she oliguric? And there are certain steps we need to do for that. Now, when we are talking about management of PPH, there are two things that we have to do simultaneously. There are obstetric measures and there are supportive measures. And these go on together at the same time. You can't split them. You can't say, I'm going to do only this or only that. But you have to have all the protocols in place so you know what's going on. The first thing, as I said, is uterine massage and bimanual uterine compression. If you can see there, you put your full, you put your full fist in there, entire fist, and on that fist you bring the uterus and pull it up. When you do that, the uterines on the side get kinked, and therefore there's decreased bleeding. So this is the first thing you're doing, and because both your hands are occupied, others have to do everything else. And what do? They call all the nurses, all the doctors, even if it's your pediatrician who's come to take care of the baby, it's enough to have somebody in there who can, monitor certain things. Bring in whoever is there available for you, all the nurses, as many doctors inside as possible. Inform the theater. Let them start getting ready, because you can't, as I said, time is of the essence in PPH, and I'll tell you why. And you have to inform the theater, call the anesthetist, where are they? Are they in another case somewhere else? All of us don't have the luxury of having an in-house anesthetist, so you call them, make sure that they are available, they can come in, call the blood bank, find out how many units of this particular blood group they have, right? That's when you suddenly realize that they have 1 unit of whatever, maybe it's O positive. And so you call them, start liaising right there, and then inform the laboratory that we are going to send blood, because in obstetrics, this never happens at 9:30 a.m. This happens at 2 a.m. when everybody, or particularly on a holiday, when things are shut down, people have gone on vacation, you get caught, that's when all these things happen. The other next thing is that you start off your oxytocin. We have already given oxytocin, 10 milligrams IM. Now you put in 10 to 20 units in your 500 ml of fluid, which is usually normal saline or lactated ringers. You put that in, and it's a stepwise increase. Next thing, if you want, you can give methergin. PGF2 alpha, it's always in the refrigerator. So the moment you start bleeding, you tell your nurse to get it out, because it has to be at room temperature. So have it removed out, whether you're using it or not, make sure that it is out and it's warming up. In Chennai, it will take about 5 minutes to reach to room temperature. So because it's hot, and I'm sure here also. But so anyway, you get it out of the refrigerator. Make sure that you have your long IM needle because it has to be given deep IM. So you given your oxytocin, she's still continuing to bleed, you can give methergin, she's continuing to bleed, give PGF2 alpha, you give 250 milligrams, you give it every 15 minutes up to a dose of, up to 8 doses. But the problem with that is they also throw up. So, you know, maybe one dose and then maybe another dose. An interesting thing, study is going on right now, the woman study about injection tranexamic acid. We don't know if we should be using this routinely for, as a prophylaxis against PPH, should we be giving it for women who have just delivered. So this study is going on, it's an international study, they're going to look at 15,000 and the study will be over in December 2014. So let's see if injection tranexamic acid, 1 gram given at the time of delivery will prevent or help in PPH. We still have to wait for those results. At the same time, the IV access is being established. Now, don't feel hesitant. Don't say, oh my God, the patient will realize something is going wrong if we start another IV on the other side, okay? It does not matter if you start an IV and it's of no use because she didn't need it. It's better to start it before the veins collapse. And at that time, everybody will be struggling to get the IV in. So get the second started. Please don't use those silly butterflies or small needles. It has to be at least an 18 gauge needle, right? Also put in a Foley catheter because, as I said, oliguria is a sign, cardinal sign of shock. So you need to know how much urine output there is. So get a Foley catheter in, get the IV access in. As I said, oxytocics are given stepwise. We have given the oxytocics. Misoprostol made a bit of a noise for a while, and everybody said we must have it in the labor room. But we know now that misoprostol is not indicated if you have injectable uterotonics with you, right? So if you are in a rural area where there are no injectable uterotonics, then you can put in 400 to 600 rectally, and it takes 20 minutes to act. Remember that. It's not going to act immediately, so it's really not going to be of very much use in PPH. As I said, the injection tranexamic acid, we are waiting to hear whether that's what we are going to start using or more of it. I have never used it for PPH, but we need to wait for the results. Right. At the same time, we felt the uterus was boggy, but that's not enough to just stop with that. We always go back and inspect the cervix. And how do you inspect the cervix? You put a speculum posteriorly, if necessary a speculum anteriorly, put ring forceps on the cervix, go all around, take a sponge holder, put a gauze, push the whole cervix way up till you see the side lateral walls of the vagina and the fornices. Make sure that you're seeing it clearly. Have your assistant hold up the speculum. It has to be done so you have to have the speculum in the labor room all, you know, packed and ready so that you can have these sterile instruments ready for you. And if there is any tear, repair it. At the same time, when the drip is being started on the other arm, draw blood for labs. Draw blood in a simple plain tube, even today. Evidence, good evidence. Put it in this thing and somebody just keeps shaking it and looking at it. In 8 minutes, if it hasn't clotted, you're also dealing with depletion of coagulation factors, right? So keep that. That's a very simple thing. You may not be able to access fibrinogen immediately. You may not be able to do a platelet count at 2 o'clock in the morning. So this will at least tell you you're getting into trouble. At the same time, send blood out for typing and cross-matching. Right. The next thing that you do is that you start oxygen by mask. Here was this woman who was getting restless because she is getting decreased oxygenation to her brain. Start oxygenation by mask. You have to give fluid resuscitation, and I'll talk about that. And at the same time, you also try, especially in an atonic uterus, there are no other tears, you start doing a uterine tamponade. And for a uterine tamponade, always have this gauze packed and ready for you so that you can open the pack and start using it. You can carefully layer it, push it all the way to one corner, layer it across, and then keep pushing it back and forth through the cervical os and leave the last bit of the gauze hanging out. The concerns are that you might be concealing the hemorrhage. The uterus is just getting bigger and bigger and distended, and blood is collecting in the gauze. And so there's one of the problems. That is one of the worries. Balloon tamponade can be used. You can use all the fancy ones, or you can use a simple condom tamponade. You can just see it there. Where it is tied into just a regular tube, and you push the whole thing and it will fill up the cavity of the uterus, or multiple Foley catheters have also been described. Right. Fluid resuscitation, please do not delay. There is no question about it. You have to pour in fluid, and crystalloids are what you need to pour in. You start with normal saline or lactated ringers. Probably normal saline is, there are, questions about which is better or not. There's a lot of evidence either way. It doesn't matter. But rapidly infuse 2 liters, that is 4 bottles immediately. Okay, because you want to maintain the systolic at about 90. Continue to give the fluid, and then you also want to maintain the urine output at about 30 ml per hour, and that's why we put in the Foley, because somebody is going to continuously look at the bag and tell us urine is forming, no urine, whatever. They keep telling us, they monitor, because there's 2 people who are in charge of the blood pressure, the pulse, the urine output. They are checking all these things. They are constantly looking at that, right? Or at least one person. Colloids, there is ample evidence not to be used. We've always used starch, because when you don't get blood, you give starch, the BP raises up. We are very, very happy. But there's very strong evidence that starch can cause acute renal injury. So please don't use hyperonchotic starch, don't use any colloids, use only crystalloids, pour this in. And there is some evidence that you don't have to worry about the blood pressure coming up. There's a lot of evidence in acute trauma, and that can be, extrapolated to postpartum hemorrhage, that you don't have to keep the blood pressure at systolic of at 100 or 110 or 120. 90 is fine. Just leave it there as long as it's staying at 90. That is perfectly all right. Obviously, blood is what we require. Okay, so when you're ordering for blood, if you can get it, 4 to 6 units of packed cells, 4 to 6 units of FFP, and platelets, if you can lay your hands on them. If it's available, that's fine. But you start off with depending on the kind of bleeding, I don't think in a PPH you're going to stop with 2 units. If it's massive PPH, you'll need to give much more. But start off with at least 2 units of packed cells, 2 units of FFP. And why FFP? Because when there is rapid bleeding, when there's excessive bleeding, then there is a huge, the coagulation factors are being used up, and therefore there's going to be a depletion of the coagulation factors. In this patient, since the bleeding was not being controlled with all the measures that had been adopted, the patient was taken to the operation theater. Now, when you delay, as I told you, there is depletion of coagulation factor, and you end up with consumptive coagulopathy, and you say, oh my God, she's got DIC, she's got DIC. The reason she got DIC is that we were not rapid enough about taking her to definitive treatment. And in all this, please don't forget to speak to the family. Please don't, sometimes if it's a crowded OP, don't send your junior most person out to talk to them and say, oh, we are taking her to the, we might be doing the hysterectomy, we might, she's in trouble, she's very dangerous. Please sign the permit that, we are going to be, that can be a very dangerous situation. Have one senior person, even if, as I said, it's your neonatologist or your pediatrician or your anesthetist who talks to them and explain what's going on, because you're with the patient, you may not be able to talk to them directly. Have them tell them what's going on. Get a permit for an exploratory laparotomy, and discuss the possibility of a hysterectomy. You know that it's a very, very bad situation at this point. You have to be very calm. You have to explain to them. And if necessary, because you have time between shifting the patient to the theater, you yourself can also go and calm the family down and explain to them what's going on. Communication is what is going to prevent you from getting into medico-legal cases. As Dr. Piley has already explained, you can then go ahead and do the internal iliac ligation, which I have not done in years, because it's a very easy procedure, but we didn't find a need for it. We do a uterine artery ligation if necessary, or of course, the B-Lynch brace suture, we found that extremely useful, and particularly only in an atonic uterus or bleeding from the placental bed, particularly in a placenta previa. So B-Lynch brace suture, and of course in very unfortunate situations we end up having to do an abdominal hysterectomy. Now, it's not enough to just send the patient home. You have to have a certain amount of follow-up, particularly look for failed lactation. That's going to be your first sign that this patient is going in for a Sheehan syndrome. So PPH is a very difficult situation for all of us. All of us have faced it, and it can put the mother's life in danger. It certainly tests your coronaries. After you've gone through a PPH, you don't need a stress test. You don't need to do a treadmill. You just know that your coronaries are fine because you survived that, especially a massive PPH. So if you have your protocols in place, I think we can send home a live mother with a healthy child. Thank you very much.